got a study on meniscus surgeries that I've been looking at discussing for a while, and it's an older study, made 10 years ago or so. It was done in Finland. It's called the Fidelity Study, and it was a pretty important study in orthopedics at the time. But I still see some of these mistakes being made even now. So I just wanted to let's dive in. So if you were told that this study, and it is a pretty important orthopedic study, was performed, and it found that people who had a sham surgery improved just as much as people that had had a real surgery, would you believe that both people had similar outcomes? And this is something that had happened in this study, this Fidelity study that they'd done in Finland. And I just want to make sure that I preface it by saying this isn't a surgery this isn't a video that's anti-surgery. Surgery has its place, but the question that needs to be asked more often is, does the surgery work? The question is, when does the surgery that we're prescribing actually help someone? And these are very different conversations. That was kind of what the study was trying to decipher. So people in Finland, it was a very elegant orthopedic study. They took patients that had degenerative meniscus tears in their knee. So just to keep that in mind as we move along, these weren't traumatic, what's called bucket handle tears, or these weren't people that had their knees locked in place because of a traumatic meniscus injury. These were just what were considered more common age-related tearing, fraying of the meniscus. Everyone in the study went into an operating room. Everyone had an incision on their knee. Everyone went through anesthesia. I mean, they really went hard on this study, but only half of the people who went under anesthesia actually had the meniscus trimmed away. The other half of the people had what's called a sham surgical procedure. So the surgeon looked in the knee, but they didn't take anything out. They didn't remove any meniscus tissue. Then they woke the patient back up. So pretty bold. And patients didn't have a clue which procedure they received. They were blinded to the procedure. And the clinicians that turned around later and evaluated all the outcomes were also blinded to who had which procedure. So a year goes by. Both groups are better. Both groups have improved pain. Both groups have improved function. Both groups had people that were returning to activity. And the important part of it is the patients that had a real surgical procedure done to their meniscus did not improve more than the people that had the sham procedure. So you'll just kind of sit with that for a sec as we move on. And then they turned around and talked to these people again 5 years down the road. And they're wondering, well, maybe surgery just takes longer to show the benefits, like the lines will start to diverge over time. And what they found 5 years down the road is there's still no statistical meaningful difference in pain and function between the groups. And what they were showing is the group that had the actual surgery done was starting to see greater progressions of knee osteoarthritis on the x-ray compared to the people that had the sham procedure. So again, there was no meaningful advantage in the outcomes that anyone cares about between the people that did and did not have an actual surgery to their meniscus. So let's put it all into context. So what we're not saying is that surgery never works. That's not what we're saying. It just means that we have to stop assuming that every MRI finding needs to be removed from a patient. Just because you can see a torn meniscus, that doesn't mean that that's what's keeping that person from improving. And that's a big distinction to make when we're trying to guide people to the best treatment options to get over their concerns. And just to make something very important distinction, the study did not look at every type of meniscus injury that can happen to people. These were what's called degenerative meniscus injuries. Yeah, so if you're playing soccer and you're 22 years old and you twist your knee and you get what's called a bucket handle tear of the meniscus and it flips in and locks your knee joint in place, that's a different conversation. That's something that we're going to have to work on, probably surgically. And then anyone whose knee gets mechanically locked by a meniscus tear, again, we're going to have to probably remove that piece of meniscus. Those are different conversations, and there's if there's significant instability related to it, maybe we got to do a surgical procedure. But evidence-based medicine isn't about applying one study to everyone. It's about knowing who the study applies to. And when I'm in clinic, I see plenty of people who have had meniscus tears shown to them on MRI. Many of them are going to improve just fine with progressive strengthening exercises, load management, enough time, restoration of confidence in their abilities to use their knee, and helping them stop organizing their entire life around the MRI finding that they were shown. And that's where the rehabilitative process really shines in these instances. And people sometimes, in the rehab setting, a lot of times people think you're either pro-surgery or anti-surgery, and I'm not either. I'm pro correct treatment. Sometimes surgery can change someone's life, and I've talked about people in the past on the channel who absolutely needed surgical procedures, but surgery should solve a problem that rehabilitation can't solve, and it shouldn't replace rehabilitation, and that's where people get confused. So this fidelity study, it was called, it didn't prove that surgery of the meniscus is useless. It proved something that's more important. It challenged all of us to start asking better questions about these procedures. Now the question isn't, can we operate on this? The question needs to become, will the operation improve the person's life more than just good rehabilitation? And that's the question that all the patients deserve to have asked. So, to kind of wrap it up, I know a lot of orthopedic surgeons, and all of your good orthopedic surgeons, they know how to operate. But the great orthopedic surgeons know when not to.